We're going to talk about Chapter 9, Antepartum Nursing Assessment. When you have a patient come in who's newly pregnant, we need to get a really good and complete prenatal history. Prenatal history includes their current information about this pregnancy and any past pregnancies they've had before. We need to know how many times they've been pregnant, how many times they have delivered a baby, if it was preterm or the babies were term, were there any abortions, whether it's spontaneous or induced, which would be before 20 weeks. We need to know, as far as past pregnancies, how they delivered. Was it vaginally or via C-section, and why? And we also like to know how the babies did after delivery. Did they have any problems? Did mom or baby have any complications? That's all important to know for the future pregnancy. With the current pregnancy, we need to know the first day of her last period. That's for LMP. Is she certain? Does she have any skipped periods? Is her periods regular every month? Is her cycle 28 days or is it longer? That all affects the estimated date of delivery. Was the pregnancy wanted or was it unwanted? Planned, maybe unplanned. Those are important to know as far as acceptance of the pregnancy and the baby itself. Did she have a pregnancy test done, and when was that? And is she having any kind of discomforts with her pregnancy so far? Common early things for pregnant women is nausea and vomiting, urinary frequency, fatigue, and breast tenderness. With past pregnancies, we also need to know how many children she has living currently. Did she use any kind of anesthesia? And was there any kind of problems or complications with that? Also important is her blood type and RH factor. We need to know if she's going to require ROGAM. And did she have any kind of childbirth education so far or in the past, or is she planning to? Current and past medical history also includes use of substance abuse, and that includes alcohol. We want to know if they smoke cigarettes, and we want to inform them of the risk of those habits. Smoking, as we know, can cause small for gestational age babies, IUGR, intrauterine growth restriction. We don't know how much alcohol it takes to cause fetal alcohol syndrome. Gynecologic history, we need to know when the last pap smear was, if it was current, did it come back positive or negative? Have they had recently, especially any vaginal infections or sexually transmitted infections? Any history of pelvic inflammatory disease? Any past surgeries? Was there any history of infertility in the past? And were they using any kind of contraceptives when they became pregnant? Past medical history includes any childhood diseases, any past treatments. Have they ever been hospitalized and what for? Surgeries. Have they had a blood transfusion in the past? And do they have any bleeding disorders? Genetic history includes any types of birth defects in the family, any recurrent pregnancy losses or stillbirths. We like to know the religious and spiritual and cultural beliefs or practices that helps us to help them accomplish those goals during pregnancy and through labor, especially if they have any particular practices that they want to include or be involved with during that time. Occupational history, do they work outside the home? Do they work in a hazardous area? Is their job very physical? Do they have to lift anything heavy? And are they exposed to anything toxic in their occupation? We also need to have information on the birth father. We need to know his age. Does he have any health problems? Blood type and RH is very important. And also, is there any genetic conditions or diseases in his family? Personal history, how old is our patient? That's important, definitely, especially if they're a teenager or if they're an older adult. We need to know if they have adequate housing. Do they have support people? Have they accepted their pregnancy emotionally, or are they having any trouble with that we can identify? Any kind of physical deprivation, signs of abuse. And it's not only important to observe for signs of abuse, it's important to ask your patient in a one-to-one basis, preferably if they have had or any forms of sexual or physical abuse, or are they afraid to be in their home? Any problems like that. Risk factors we want to identify early in the pregnancy for the best outcomes, and we want to identify those risk factors continuously throughout the pregnancy. With pregnancy and birth history, we can use the acronym and make sure you're familiar with that to list their history down. Gravida is how many times they've been pregnant, all pregnancies, no matter whether they were term or preterm or less than 20 weeks. We count them, how many times they've been pregnant. T, were they term? P is, were there any preterms? A, were there any abortions, whether it's spontaneous or induced? And L is living children. Remember, there's gravida, there's also para, is how many deliveries they've had. And here's that explanation as well. Risk factors. We need to know if a risk factor is a low income situation. Low income is associated with less environmental opportunities. Also with diet and nutrition. Poor diet can lead to inadequate nutrition for both mom and baby, increase of preterm birth for mom, and risk of anemia. She also has a high risk of preeclampsia just with a poor diet. Fetal and neonatal implications include fetal malnutrition, IUGR, intrauterine growth restriction, and SGA, small for gestational age. Also, prematurity is a factor. Multiparity greater than 3 leaves mom with a high risk antepartum wise or postpartum of hemorrhage. And the fetus is at risk for anemia and fetal death. Weight, less than 102 pounds or more than 200 is a factor for women who are pregnant. Poor nutrition affects this. How much weight they should gain affects this. If their weight is less than 100 pounds, then they're at risk for a IUGR baby or SGA, hypoxia associated with a difficult labor and birth. If they're over 200 pounds, they have a higher risk for low fetal nutrition and high risk for macrosomia. If they're less than 16 years old, poor nutrition is a risk factor for the teenagers, insufficient prenatal care, and they have a higher risk of preeclampsia and cephalopelvic disproportion. Low birth weight for the baby can lead to also high fetal demise. If they're over 35, you're going to see those have a higher risk of preeclampsia and a high cesarean birth rate. For the baby, high risk of congenital anomalies and high chromosomal abnormalities as well. Smoking definitely can cause risk for both mom and baby, especially if it's 1 pack a day or more. Mom's at risk for hypertension and cancer. Baby is at risk for low placental perfusion, low oxygen and nutrients availability, low birth weight, both IUGR or SGA, and preterm births. Addictive drugs leads to poor nutrition for mom, infection with IV drugs, high HIV and hepatitis C risk. These addictive drugs lead the fetus or neonate to be at higher risk for congenital anomalies, abruption, high risk for low birth weight, and within neonates, just as the mom, you will see withdrawal from these addictive drugs. Alcohol leads to poor nutrition and possible hepatic effects for mom. High risk for fetal alcohol syndrome in the baby. Pre-existing medical conditions such as diabetes. Diabetes can cause episodes of hypoglycemia and hyperglycemia. Mom with diabetes is at risk for a higher risk for a C-section, placenta previa, and she's at high risk for preeclampsia. For the fetus or neonate, they are at higher risk for preterm labor or birth, high risk for stillbirth, high risk for fetal demise, IUGR or SGA, and high risk for malpresentation. They also have a high risk for stillbirth. Macrosomia in neonates because of diabetes is also a risk factor. Other disorders include cardiac disease. Maternal implications include cardiac decompensation, further strain on mom's body, because of the further strain on mom's body, and high maternal death rate there is. Fetus and neonatal implications include high risk for fetal demise and high prenatal mortality. High blood pressure leads to vasospasms for mom, high risk for central nervous system irritability and convulsions, high risk for cardiovascular accidents, which is a stroke, and high risk for renal damage. Excuse me. Fetal or neonatal implications include low placental perfusion, low birth weight, and preterm birth. Thyroid disorders are also a problem or can be. They are at increased risk for high infertility rates. For the baby or the neonate, high spontaneous abortion is common or is a common risk for thyroid disorders. Hypothyroidism and hyperthyroidism. Make sure you review, excuse me, the risk for both mom and fetus. With the RH and blood and group sensitization, it's important to know mom and dad's blood types and RH factors. For the fetus or neonate, the implications, the risk are erythroblastosis fetalis, hydrops fetalis, neonatal anemia, kernicterus, and hypoglycemia. One other risk factor, especially associated with diabetes, is a large baby. And a large baby causes a high risk for mom to have a C-section. And if she has a very large baby, she's at higher risk of having gestational diabetes. For the fetus or neonate, they are at higher risk for birth injuries and hypoglycemia. Rubella, if exposed to rubella during the first trimester, the fetus is at high risk of congenital heart diseases, cataracts, nerve deafness, bone lesions, and prolonged virus shedding. The first few weeks when the baby is forming, if they're exposed at that time, the more damage that they'll have. Toxoplasmosis disease is a disease that results from infection with the Toxoplasmosa parasite. Eating undercooked, contaminated meat and exposure from infected cat feces puts mom at higher risk of contacting this infection. Mother to child transmission during pregnancy is very possible. Fetal and neonatal implications from this infection include potentially blinding, retinochoroiditis, convulsions and coma, and microcephaly is a high risk as well. Cytomegalovirus is a common virus. The body retains the virus for life. An active CMV infection can be passed to the baby, and implications for the baby is intrauterine growth restriction, encephalopathy, preterm birth or premature birth, late signs of hearing loss, and developmental delays. The herpes virus type 2 causes severe discomfort for mom. There's a possibility for a cesarean birth, especially if she has an active outbreak. And also fetal infection is a risk. Neonates or fetuses who are infected, about 2% become infected with hepatitis, with jaundice, and they will demonstrate neurologic abnormalities or may demonstrate neurologic abnormalities. Syphilis causes a high incidence of abortion for moms. For the baby, there's a high fetal demise rate and congenital syphilis. HIV positive women have higher infections of candidal infections, wasting syndrome, and usually concurrent sexually transmitted infections such as herpes. Postpartum hemorrhage and poor wound healing are also risk of HIV positive women. For the fetus or neonate, the transmission of HIV is a definite risk. Obstetric considerations that we have to think about is abruption or abruptio placenta and placenta previa, which leads to a high risk of hemorrhage. Mom will be on bed rest probably with this and will need an extended Obstetric considerations that we have to think about is abruption or abruptio placenta and placenta previa, which leads to a high risk of hemorrhage. Mom will be on bed rest probably with this and will need an extended hospitalization. The fetus or neonate may have anemia, intrauterine hemorrhage, and there's a high fetal demise rate with abruption and placenta previa. Preeclampsia or eclampsia, remember the difference is it becomes eclampsia once the mom has had a seizure. So know your risk for high blood pressure or hypertension along with that. Fetal and neonatal implications include high placental perfusion. Sorry, that should be low placental perfusion, and low birth weight. Multiple gestations. Maternal implications include high risk for postpartum hemorrhage, high risk for preterm labor, and high risk for gestational diabetes. Multiple gestations includes the risk for preterm labor, placenta previa, and preeclampsia. For the fetus or neonate, they have an increased risk of preterm birth, stillbirth, fetal demise, intrauterine growth restriction, and small for gestational age babies, malpresentation, and stillbirth. Another obstetric risk or consideration is spontaneous rupture of membranes. With the rupture of membranes, moms are at an increased risk for uterine infection. Babies or the fetus or neonates are at increased risk for preterm birth and fetal demise. So with any type of spontaneous rupture of membranes, whether it's preterm or at term, we want to definitely limit the number of vaginal exams that are done for mom, because every time something is introduced into the vagina, there is now no barrier, and bacteria can enter in through that way and cause infection. There's many pregnancy changes that happen that are normal, and you'll need to do a lot of teaching with your new clients. Skin and hair changes. You tell moms that they're going to see an increase in skin pigmentation. It's usually caused from the increase in estrogen and progesterone. They may see silver striae, which are like stretch marks. They may be purplish to start with. The nose becomes more stuffy due to edema. Metabolism increases during pregnancy because of the demands of the growing fetus. Weight gain is important. It's important to know the pre-pregnancy weight along with the current weight. Recommended weight gain for an average female at a normal weight is 25 to 35 pounds. If they're overweight, they may be recommended to gain as little as 15 pounds. And if they're underweight, they may gain up to 40 pounds. It's important to encourage mom to continue her dental checkups, as a hypertrophy of gingival tissue is more likely during pregnancy. Also with the thyroid, by the 3rd month can come hypoplastic. Breast definitely increase in size and tenderness, usually by about 20 weeks. And this is due to the estrogen and progesterone levels that increase. So the increase in size also has an increase in the number of mammary glands. The nipples become more erectile and the areolas darken. Colostrum is usually produced by the 3rd month, the 3rd trimester, but it can be noticed as little as 12 weeks, especially if they have had babies before. They may notice heart palpitations during the pregnancy. This is due to increased levels of estrogen and progesterone again. Cardiac output and blood volume increases during pregnancy. The heart rate increases about 10 beats per minute. during the pregnancy. They'll see an increased size of the uterus, causing interference with blood return to the lower extremities. Therefore, they may see some lower extremity edema. Increased levels of red blood cells are there to increase oxygen delivery to the cells. Also, clotting factors increase during pregnancy. Moms may develop a benign short systolic murmur during pregnancy, which usually resolves after pregnancy. With the respiratory system, we're going to see increasing levels of progesterone causing an increased volume of air, decreased airway resistance, increased anterior-posterior diameter, and thoracic breathing, which occurs as the uterus enlarges. The GI system, usually because of progesterone, you're going to see delayed gastric emptying and decreased peristalsis, which can lead to constipation for the pregnant women. You're going to notice more curvature to the spine to make up for the balance difference with the extra weight on one side. The vagina is usually, it will be pink or dark pink, and odorless, should be clear discharge may be present, and that is normal. This increased vaginal secretions helps to prevent bacterial infections. The connective tissue in the vagina relaxes. The uterus increases because of estrogen and because of the growing fetus. There's increase in weight, strength, elasticity, and vascularity of the uterus. Also, the cervix becomes more hyperplastic, and the formation of a mucus plug occurs, which helps prevent organisms from entering the uterus. With the pelvis or the cervix, you'll see a softening of the cervix happen, which is called Goodell's sign. The cervix itself takes on a bluish color, and that helps identify pregnancy with an exam, and that's called Chadwick's sign. Estimating the expected date of birth or the expected date of delivery can be easily done. There's several different ways to do it. You can use a pregnancy wheel. You can measure fundal height. Nagel's rule, remember, that is using a generalized number of 280 days, assuming that's the gestational age of everybody. We have to remember that not everybody's cycles are the same. Some last longer. So actual LMP dates may be off a little bit. So this is a good way to get a quick estimated date of delivery, but it will not be precise. You do this by calculating you calculate the due date, assuming that it's 280 days gestation. So the rule has you add 1 year, subtracting 3 months, and then add back 7 days to get the estimated date of delivery. The pregnancy wheels use the last menstrual period to help determine the date. We can measure uterine size by determining fundal height. Using a tape measure, we measure mom's fundus from the top of the symphysis pubis to the top of the uterine fundus. Quickening is the movement, the first movement that mom starts to feel or perceive as fetal movements. This normally occurs about 20 weeks of pregnancy, but it can be noticed earlier, about 13 to 16 weeks, especially if they've had a pregnancy before. We can auscultate the baby's fetal heart tones using several methods. The ultrasonic Doppler device lets us take a look at the baby, measure the baby, and also look at the baby's heart and count fetal heart tones. There's two different types of fetoscopes. One will let you look at the fetus, and one will just use like a stethoscope. It's called a Doppler, and that lets you listen to fetal heart tones without seeing the baby. With clinical pelvimetry, be sure and make sure you remember where the pelvic inlet is, the pelvic outlet, and make sure you remember what direction, how to use your hand to measure the diagonal conjugate and the anterior posterior diameter. Okay, moving on to major prenatal screening tests. All moms, when they come in, if they haven't had a pap smear recently, will have a pap smear. They will get a CBC, blood drawn, complete blood count to check their hemoglobin and hematocrit, making sure they're not anemic. They will have an HIV screen done, urinalysis and culture, looking for infections, and also maybe drug use, and a rubella titer to make sure they are immune. Other tests will be ABO and RH, checking their blood type and RH factor. Hepatitis B screen. Sexually transmitted infections will be a screen for. And women who are at risk, they may have a hemoglobin electrophoresis completed. This looks for sickle cell disease and thalassemia. The tuberculin TB skin test is indicated for women at high risk if they were born outside of the United States, if they have known exposure to TB, and for healthcare providers who care for patients with TB. And there is also cystic fibrosis screening. Checking for anomalies, we can have phenochromosome tests done. There are several different ones that can be completed. The screening is offered to all pregnant women of all ages, and these screenings look for and detect anomalies such as Down syndrome, trisomy 18, trisomy 13, and Turner syndrome. The quadruple screen or quad screen checks for several things, but one of the main things it looks at is for alpha fetal protein, and that checks for neural tube defects. Responsibility for us as healthcare providers is to make sure the parents have all the factual information available that they need to feel comfortable with the tests and with the results they may receive. Discussion of false positive results and detection rates needs to be completed before the test. Implications of findings need to be discussed as well. And just be sure and remember that parents have the choice to take action based on their own decisions. And those are usually based off of spiritual and cultural beliefs. Additional screening is gestational diabetes mellitus. All women are usually screened for gestational diabetes. The screening is usually done between 24 and 28 weeks. If the first screenings come out positive, that shows a need for additional tests. Gestational diabetes is a type of diabetes that's first seen in pregnant women that did not have diabetes before she was pregnant. Some women have more than one pregnancy that's affected by gestational diabetes. And it usually shows up about midway through pregnancy. Maternal implications for diabetes is a high risk for placenta previa, high risk for preeclampsia. Fetal and neonatal implications include high risk for preterm labor or birth, high risk stillborn, high risk for fetal demise, IUGR, and SGA babies, high risk for malpresentation, usually due to fetal size being very large, and high risk for stillbirth. I think I said that. Okay, Group B strep can cause lots of problems for the newborn. Moms that carry it usually are not symptomatic. If the mom is positive for Group B strep, then antibiotics are normally given to her during labor as prophylactic therapy. And the newborn will be monitored if the mom was positive. Women are usually screened for Group B strep in the office between 35 and 37 weeks gestation. And some women who come in to labor and delivery or present in labor without previous prenatal care will be screened at the time they come in. Okay, so there are several danger signs in pregnancy. So we need to discuss some of those signs and possible causes.
Hold on just a second.
Okay, so there are several danger signs in pregnancy. So we need to discuss some of those signs and possible causes. A gush of fluid from the vagina is usually a sign of premature rupture of membranes. So moms should be instructed to always be checked out and let the doctor know if they feel like they are leaking any fluid. Vaginal bleeding is related to abruption or placenta previa, or may possibly just be bloody show from early labor itself. Abdominal pain can be related to premature labor or abruption. Fever above 101 degrees, especially when associated with chills, is a sign of infection. Edema, especially when it moves to the hands and face, generalized edema is definitely a high risk. It may be associated with muscular irritability and convulsions and epigastric pain. All these are risk for preeclampsia or eclampsia. Oliguria and dysuria are important for both preeclampsia and even UTIs. And any absence of fetal movement is a danger sign and needs the physician or healthcare provider needs to be notified immediately. I'm going to continue with a few more danger signs before going back to on with this screen. So dizziness, blurred vision, spots before their eyes can be signs of hypertension and preeclampsia. Persistent vomiting is related to hyperemesis gravidarum. Severe headache, remember your hypertension and preeclampsia signs. Edema again of the hands, face, legs, and feet are signs of preeclampsia. So for subsequent visits, after mom has come in and you've gotten most of that information, we will need to continue to collect information to make sure her pregnancy going is as expected. This helps get better outcomes for both mom and baby. So we need to know how she's responding to her pregnancy, and actually how the whole family is responding to the pregnancy is helpful information. Is the support person adjusting to the pregnancy and the plan of having a new baby at home? And also, are the children, how are they doing with that information? Is mom preparing for having a new baby at home? Or maybe she hasn't done anything to prepare for this baby, which is a risk factor you need to note. Discomfort, does she have any new discomforts that are going on, especially as pregnancy progresses? Discuss those and reassure her. And physical changes, continue your education on changes that occur as pregnancy progresses.
I'm going to pause just a minute to switch the PowerPoints to chapter 10. If you want to take a really quick break, now would be a good time.
Chapter 10, the expectant family needs and care. The nursing process during pregnancy. A written care plan or plan of care will include the database of normal changes of pregnancy, the nursing diagnosis, along with the client goals. This leads to continuity of care. Nursing diagnosis will vary among women to women.
Sorry, I've got to start that one over one more time.
From women to women, and priorities of nursing care are included. Priorities of nursing care are sometimes based on the most immediate needs or concerns identified by the women. Priorities may develop from findings during a prenatal examination. Taking care of the expectant father or partner. The father may need guidance and information on the anatomic, physiologic, and emotional changes that occur for the expectant mother during and after pregnancy. sexuality and sexual response, and the reactions that he is experiencing to the pregnancy. Allow fathers or partners to express their feelings about the pregnancy, about feeding, ability to parent, and also about sexual activity. If it's culturally appropriate, be sure and recommend childbirth classes. That helps them gather more information and become more confident. Increase your focus on father's needs, helps them to make transitions into being a father a little bit easier, and decreases the stress levels that prenatally they may be having, especially when it's associated to the healthy behaviors or not healthy behaviors of the mother prenatally. In women who receive continuous support, cesarean section rates and the use of epidurals has been shown to be significantly decreased. Taking care of the siblings, discuss any negative feelings that the siblings may have if they're able to verbalize that to you, or that the parents might be having going on or feel like is going on with their children that may be occurring during the birth of a new child. This will help children to master their feelings and take control. They'll feel less neglected and more secure if their parents are talking to them about these issues and these feelings. And it'll help them to work on their feelings of anger and resentment, jealousy type issues, if they know they have open communication with their parents and that they can talk to them about these feelings. Cultural considerations. Each childbearing family has different expectations of both the person and the healthcare system as well during pregnancy and birth. Language barriers often pose a challenge, especially to healthcare providers. Be sure and have an interpreter available and printed information in the woman's language that she can refer to. Remember, not every culture believes that the father of the baby should be included during childbirth, and that is definitely up to those parents. So we need to respect their belief system. Decisions that parents make regarding childbirth preferences and experiences. There's many decisions that they're going to face. A birth plan is helpful in identifying aspects of childbirth that are most important to them and to tend to the birth. They should always know that they should have someone to watch children that they may want present for the birth that can actually take care of their primary needs while mom is in labor and that while both of them are going through the birthing experience. The birth plan helps to identify options that are available to them both during pregnancy and delivery. It can also be used as a tool for communication among parents and their healthcare providers at birth. Setting priorities, talk to them about setting priorities in their birth plan regarding maybe ambulating during labor, showering, monitoring, whether it's intermittent or continuous, internal versus external monitors, things like rupturing membranes early, amniotomy, using medication during labor or epidurals or non-medicated labors. So be sure and encourage moms to discuss this with their healthcare providers well before their intended time for labor. There are many decisions they can choose as well as for healthcare providers. You may be talking to a new mom who isn't sure about where to go, so you can give them lots of information regarding OB doctors that are available, certified nurse midwives, a family physician. Birth settings, including hospitals, birth centers, and home births can be discussed. Support during labor, whether they may want a doula present, that someone, a professional person that helps with labor. Siblings, again, do they want them in the room? What is their age? And if they do want them in the room and they may require attention, again, have someone available for them to take care of their needs continuously. Goals of childbirth education is to give them updated evidence-based information regarding labor and birth, regarding pain relief, complications and procedures that may arise, breastfeeding information, newborn care, and help them with postpartum adjustment. Remember, it's not just mom. We also want to include the father or the partner with this information. Be sure and review page 200, table 10-2. These are some topics that childbirth education will discuss with moms and their significant other. It includes gestational changes, fetal development, choices they may be able to make, preparation for a vaginal birth or a cesarean birth, information on VBACs. There are often classes available for grandparents and siblings, newborn classes for care and safety, and postpartum classes. These classes assist with helping mom with rest, exercise, and nutrition for postpartum. Newborn classes help with bathing newborns, cord care, circumcision care, and childbirth education will also help teach episiotomy care, both during then and in postpartum classes. Causes of discomfort during the first trimester can include nausea and vomiting. It can be caused for many different reasons. Elevated HCG levels, changes in metabolism of carbohydrates, and emotional factors can also facilitate nausea and vomiting. Urinary frequency is common in early pregnancy. The enlarging uterus starts putting pressure on the bladder. Fatigue is caused by getting up several times a night to go to the bathroom, and hormonal changes. Discomforts, continued increased estrogen and progesterone levels can cause nasal stuffiness. We talked about this a little bit in the first chapter. Breast tenderness, increased vaginal discharge, cervical hyperplasia, and increased production of mucus by endocervical glands. Heartburn is common later on in pregnancy during the second and third trimester. That's usually because of increased progesterone and the decreased gastric motility. Also, the size of the uterus can affect where the stomach is and how much a person can eat at once. So several small meals is usually better than the 3 big meals to decrease heartburn. Mom shouldn't lay down within a couple hours of eating. Ankle edema is because of slow venous return and can be because of increased levels of sodium. We don't need to tell mom to stay completely away from sodium, but not eat extra sodium, like chips. Varicose veins are caused from venous congestion and weight gain. Hemorrhoids are also hemorrhoids are the same thing. They are varicose veins caused for the same reason. Also from pressure of the uterus and the weight from the uterus. Constipation plays a role in causing hemorrhoids as well. Backaches, because of the increased curve in the back, because of the larger uterus, and for balancing reasons. Their back may be uncomfortable. Leg cramps may be an imbalance of calcium or phosphorus. And then, of course, fatigue is a common sign in pregnancy throughout. Flatulence is due to decreased gastric motility and air being swallowed. Sudden changes in positions, which causes posterior hypotension, can lead to fainting. And the decreased vital capacity of the lungs due to the increased size of the uterus can lead to shortness of breath or dyspnea. Carpal tunnel syndrome is also common in later pregnancy due to the compression of the median nerve from edema. Relief measures: nausea and vomiting, avoid odors, eat dry crackers in the morning before they get up out of bed, avoid greasy foods, and drink plenty of fluids between meals, small frequent meals again rather than the large meals. About 80% of pregnant women have nausea and vomiting in early pregnancy. It usually goes away about the 16th week. If it doesn't go away, it can be a sign of or lead to hyperemesis gravidarum, which includes weight loss, dehydration, and a nutrition imbalance. Acupuncture, wristbands, ingestion of ginger have been shown to help with nausea. Avoiding gas-forming foods will help with the gas problem. Chew food thoroughly. Regular daily exercise, and try to maintain normal bowel habits will decrease the trouble. Dyspnea, using proper posture when you're sitting and standing will help them. Sleep propped up on pillows for relief at night if it occurs. Primogravidas normally experience relief in the last few weeks of pregnancy due to lightening. That's when the fetus and the uterus kind of move down into the pelvis and gives more room to breathe. It doesn't happen in multigravida women. Constipation, we want to increase fluid and fiber in the diet, encourage regular bowel habits, encourage regular exercise, and stool softeners as recommended by a physician if needed. With fainting, prolonged standing in a warm or stuffy environment can lead to that. We want to change positions slowly, and we want to evaluate their hematocrit and hemoglobin. For backaches, using good body mechanics, practicing pelvic tilt exercises will help. Leg cramps, practice dorsiflexion of the feet to stretch affected muscles, evaluate their diet, and they can apply heat to affected muscles. Get up slowly from resting positions. Round ligament pain is the ligaments that stretch due to the uterus as it gets larger, and it causes pain when rising up in the abdomen. So it causes pain, kind of like a grabbing sensation in the lower abdomen by the inguinal area. You can apply heat to that area to help and rise slowly to decrease those symptoms. Ankle edema, elevating their legs while they're sitting or while they're sitting. Remember, elevation needs to be higher than their heart level. Dorsiflexing their feet frequently. Varicose veins, again, elevating legs as much as they can will help support hose will help. When swelling and discomfort of varicosities can be decreased by laying down with the legs and one hip elevated to avoid compression on vena cava. So when you have a pregnant mom laying down, you want to make sure that one hip is elevated to offset the uterus. We want to encourage them with varicose veins to avoid crossing their legs at the knees and not to wear constrictive bands. Urinary frequency, both in early pregnancy and in late pregnancy, is common. They still need to increase their fluid intake, which you would want to encourage them to do during the day and less during the evening so they're not up all night. Fatigue can be aggravated by nocturia due to the urinary frequency. Encourage them to plan nap time or rest periods daily. Try to go to bed a little bit earlier for the rest. Getting help, family support with assistance and responsibilities to allow for rest time will also help. For breast tenderness, a well-supporting bra, good fitting bra is important. Avoiding getting soap on the nipple area when they're breastfeeding because it tends to dry out the nipples and cause a tenderness. Increased vaginal discharge is called leukorrhea. Remember, it should be clear. It may be a little bit mucousy, and that is normal. Bathing daily, wearing cotton underwear helps keep that from being a problem. That is a protective agent. Nasal stuffiness, epistaxis, nosebleeds, using a cool mist vaporizer can help. Avoiding nasal sprays and decongestants will also help. Monitoring fetal activity is important for mom to do at home, especially. The Cardiff counting method or kick counts is important. Mom focuses on the fetal movements and keeps a record of how often she feels them. She should feel at least 10 fetal movements in a 3-hour period. Feeling the baby move is reassuring of fetal well-being. And any decrease in feeling the baby move or cessation of movement can be a problem. Other actions to help promote health and stay comfortable: wearing comfortable clothes, low-heeled shoes, avoiding falls. There's no problem with working until labor happens, unless they're around something that could be toxic or hazardous. Travel, if complicated pregnancy, they need to avoid traveling. If they do not have a complicated pregnancy, they need to remember to stay well hydrated and avoid prolonged sitting, so frequent stops and movement. Dental care, important to maintain regular dental checkups due to changes in gum tissue. So moms should be up on their immunizations. If they are lacking any, they want to be sure and avoid any live virus vaccine, such as rubella. Exercise is okay, especially if it's not something new and it is not a complicated pregnancy. Encourage them to take frequent rest periods. For low back pain and exercise, the pelvic tilt and perineal exercises such as Kegel exercises are important in keeping those muscles strong. They help delivery go a little easier. The inner thigh exercises they can accomplish by laying on one side and lifting the leg up above the other leg. Sexual activity, they may need to talk about alternate positions due to the enlarging uterus. Avoid toxic substances, medications that's not prescribed, alcohol, smoking, tobacco, any illicit drugs, pesticides, and x-rays should be avoided. There are complementary and alternative therapies. Make sure that you tell moms that not all of them are safe. They're not regulated by the Food and Drug Administration. So be sure and research before they use and talk to their physician before they use any of these alternatives. They need to avoid herbs, especially in the first trimester, except ginger, which helps with nausea and vomiting. Remember to tell them that tobacco is one of the most significant modifiable causes of poor pregnancy outcomes in our country. Concerns about sexual activity are very common, and a lot of people feel comfortable bringing them up. But if you are able to get put in that position or able to offer that information, these are the things you can tell them. With an uncomplicated pregnancy, there is usually no problem with sexual activity up until delivery or up until labor. Of course, if the membranes rupture, they should abstain from that after that because of the risk of infection. Some concerns that are common is injuring the baby or the women, changes in desire of either partner, and communication. So communicating needs is needs to be greatly emphasized. Make sure the information you're giving them is accurate. So if they are having a complicated pregnancy, their sexual activity may be limited and contraindicated if they are threatened miscarriage or if they have any risk of preterm labor. If at any time they're unsure about this activity, they need to refer to their healthcare provider.
I may have just clicked out of the wrong one, so give me just a second and I will have the correct one up. Hold on just a minute, please.
Chapter 11, maternal nutrition. Nutritional status is very important both before and after pregnancy and can significantly influence the health of the mother and the fetus. Nutritional problems that interfere with cell division may have permanent consequences Women can get most of the recommended nutrients by eating a well-balanced diet each day. Optimal weight gain depends on the woman's body mass index, or their BMI, and her pre-pregnant nutritional state. An adequate weight gain indicates an adequate caloric intake. It does not ensure that the woman has a good diet nutritionally. The pregnant woman must maintain the nutritional quality of her diet as her weight gain progresses. A normal weight gain in a pregnant woman of normal weight is about 25 to 35 pounds during her pregnancy. During the first trimester, she may gain 1.1 to 4.4 pounds. Average gain is about 1 pound per week during the last 2 trimesters. Underweight women need to gain a little bit more than that, which would be slightly higher than the 1 pound per week during the last 2 trimesters. Overweight women would gain a little bit less, which is 0.6 pounds per week during the last 2 trimesters. And if they're very obese, it is 0.5 pounds per week during the last 2 trimesters. Maternal weight gain, just from the fetus and the pregnancy itself, is significant. 11 pounds is accounted for by the fetus, the placenta, and the amniotic fluid. 2 pounds for the uterus size. 4 pounds for increased blood volume. 3 pounds for increased breast tissue, and 5 to 10 pounds for maternal stores. So studies have found that in the US, more than 1/3 of women are obese, and 8% of reproductive age women are extremely obese. This definitely becomes a problem because of increased risk for complications during and after, or during pregnancy and during delivery. Also, gestational diabetes is higher risk with these women, preeclampsia and cesarean birth. The fetuses are at increased risk for congenital anomalies, stillbirth, prematurity, macrosomia, and childhood obesity. Remember to ask about bariatric surgery among obese reproductive age women, because that has been increasing. Primary sources of energy come from carbohydrates. Fiber is important for bowel function. And if it's unavailable, the carbs are unavailable, protein will be used for energy and for growth needs instead. So you can get your carbohydrates from dairy products like fruits and vegetables, and whole grain cereals and breads. Protein is essential acids needed for growth and development of maternal tissues and for fetal growth. It also contributes to energy metabolism. It's needed for the growth and development of maternal tissues, such as the uterus and the breasts, and to meet fetal needs. Protein comes from your meats, fish, poultry, eggs, and dairy products. Fats are valuable sources of energy for the body, and they aid in the absorption of fat-soluble vitamins. Omega-3 fatty acids and the derivative of DHA comes from fats. Maternal intake of DHA during pregnancy may reduce the risk of preterm birth and low birth weight, and may enhance fetal and infant brain development. Oily fish provides the best sources of DHA. Fortified dairy products also provides this, and some fortified soy milk. Plant sources of omega-3 fatty acids include soybean oil, canola oil, flaxseed, and their oils, and walnuts. warn women to be sure and watch out for mercury and mercury content when they eat fish and seafood. The body absorbs and uses calcium more efficiently during pregnancy. Teeth begin to form at about 8 weeks gestation. If calcium intake is low, then fetal needs will be met at the expense of the mom. Her bones will actually become demineralized due to this. Minerals, calcium and phosphorus, you can get with 4 cups of milk or an equivalent dairy product. Smaller amounts are found in legumes, nuts, dried fruits, and dark green leafy vegetables. Iodine is important for thyroid function. And sodium is also important for fluid balance. Anemia leads to a significant reduction in hemoglobin in the volume of packed red blood cells per deciliter of blood, which is in the hematocrit, and also in the number of erythrocytes. Associated with increased incidence of preterm birth, low birth weight newborns, and maternal and infant mortality. The recommended daily allowance for iron during pregnancy is 27 milligrams per day. But according to the information, it is almost impossible to achieve that number by diet alone. During the second and third trimesters, the pregnant woman should normally take a daily supplement of iron. Taking iron after a meal may help reduce discomfort, abdominal discomfort. Remember, iron supplements may also cause constipation, so adequate fluid intake is important during pregnancy. Vitamins A, D, E, and K dissolve in fat. Vitamin C and B complex vitamins dissolve in water. Vitamin A we get from deep green, deep orange, and yellow vegetables. Animal sources include egg yolk, cream, butter, and fortified margarine and milk. Also from sunlight. Vitamin D, women at risk are usually vegetarians, women with limited sun exposure, ethnic and racial groups with dark skin. They may need to be screened for vitamin D deficiency. Vitamin E comes from vegetable fats and oils, whole grains, greens, and eggs. Vitamin K is related to normal blood clotting, and we get this from green leafy vegetables. Vitamin C we get from citrus fruits, tomatoes, cantaloupe, strawberries, also potatoes, broccoli, and other leafy greens. The B vitamins, which includes thiamine and riboflavin, niacin, and folic acid, among others, come from pork, fish, liver, milk, eggs, potatoes, and enriched breads and cereals. Folic acid, an inadequate intake of this is associated with neural tube defects like spina bifida and meningomyelocele in the fetus or newborn. It's recommended that all women of childbearing age 15 to 45 years, consume 400 micrograms of folic acid daily, because about half of all U.S. pregnancies are unplanned, and this is needed very early on. The neural tube defects happen early. Fluids are very important. They work as a lubricant, a medium of transport for carrying substances in and out of the body, and as an aid for temperature control. Because of their sodium content, sodas and diet sodas should be consumed in moderation. Caffeinated beverages have a diuretic effect, which is counterproductive to increasing fluid intake. So it's recommended that pregnant women consume at least 8 to 10 glasses of fluid each day, with about half of that, 4 to 6 glasses, should be water. There are several types of vegetarian diets. Be familiar with what is available to each one. So the hardest one to make sure it gets the nutrition that is needed is the vegan diet. It does consume no animal products. See your table 11-2 on page 226 for your vegetarian food groups. The vegan diet will often need many supplements. Emphasize consumption of foods that contain nutrients such as calcium, iron, and zinc, and other nutrients that are normally found in animal products that they do not eat. Factors that influence nutrition are how they're feeling while they're pregnant. Are they having nausea and vomiting, heartburn, constipation? Remember, complementary and alternative therapies, there are a few that do help, but some can be dangerous. They do pose a risk, and they need to check with their healthcare provider. Caution them about energy drinks. They are loaded with caffeine. And again, caution them about checking the mercury content in the fish that they eat. Food and culture, there's different practices and preferences per cultures. Just be respectful and try to help them obtain their goals during their pregnancy and their labor with their nutrition status. Psychological factors that affect food choices. Remember, some food is associated with status. Socioeconomic factors definitely influence nutrition status and what food choices we make. Unfortunately, a lot of food that is less expensive is less nutritious for your body. And then again, sometimes we eat food in place of dealing with emotions, and that can affect our nutritional status as well. So the woman who may present pregnant, who is depressed or does not wish to be pregnant, may manifest feelings of loss of appetite or overindulgences in certain foods. Eating disorders are possible even during pregnancy. Anorexia nervosa is very low calorie count through the day, an altered sense of weight, excess weight that they may have. These people are starving themselves. Most of the time when they get to the diagnostic stage, they may not be having a menstrual cycle anymore. So we don't see these women come in with pregnancy as often. With bulimia, they are more common. These women may not appear to be severely underweight. Bulimia is characterized by binging, followed by purging. These women need to be referred to nutritionists. Eating disorders, one of the Most common ones is pica. Pica is a craving for things that we would consider not to be edible. It's non-nutritive for sure, like soil or clay, laundry starch. What we try to do is these women may need counseling to help them through this, but we can encourage them to take in something that's more nutritious instead of what they're eating. So consequences of pica possibly are iron deficiency anemia, which is very common. We need replacement of iron-containing foods from the diet, or they need them. And this could cause interference with iron absorption. Eating freezer frost can cause poor weight gain due to lack of appetite. Eating starch can increase weight gain. And clay cause fecal impactions. Assessing for pica, remember that they know that this shouldn't be normal and they're going to be more hesitant to discuss it, maybe embarrassed. So don't use a judgmental tone at all when you go to talk to them. Try to display empathy and try to provide information that can either help decrease or eliminate the practice, especially substitutions. Caloric needs of adolescents who are pregnant. Adolescents who become pregnant less than 4 years after their first period are at risk or at higher risk because of their physiologic and anatomic immaturity. They are more likely than older adolescents to still be growing, which can affect the fetus's development. It affects their caloric and nutritional needs. They may require an increase as high as 50 kilocalories per kilogram, especially if they're physically active and they're young and pregnant. Teens often eat irregularly. They may skip meals, they may eat late meals, or take quick snacks. So their day-to-day intake is going to vary drastically. Weight should be done over a period of days rather than each day. Supplements that the adolescent may need include iron, calcium, folic acid, zinc, vitamin A, and vitamin D. Assessment data for adolescents who are pregnant related to nutrition. We need to know their height and weight in order to determine how much weight gain they will need during their pregnancy. We need to look at important lab values that are going to tell us about their nutrition, such as their hemoglobin and hematocrit. Clinical signs of problems such as constipation, anorexia, and heartburn. And we can get a dietary history from them, have them write down what they eat for about 3 days to kind of get a general idea of their habits. And we also need to get information about psychological, cultural, and socioeconomic factors that influence their food intake. So the dietary history is information that we obtain to analyze this information and formulate an appropriate nursing diagnosis with the women and to develop goals and desired outcomes. Again, definitely by the patient, their desired goals and outcomes during the first trimester when possible. Nutrition imbalance, less than body requirements, may be related to nausea and vomiting, is a common nursing diagnosis for adolescent pregnancies. So we know that pregnant moms need to have an increased caloric intake of 300 per day. We need to emphasize to the adolescent pregnant teenager that, that a well-balanced diet is very important to help achieve their nutritional goals. Breastfeeding moms need even more calories. So they need, for breastfeeding, 200 per day over the pregnancy, which is 500 calories more per day over the pre-pregnancy weight or calorie intake, which averages about 2,500 to 2,700 calories per day. Protein, calcium, and fluid intake is very important for these moms. Chapter 12, Pregnancy in Selected Populations. Scope of adolescent pregnancy, about 1/4 of pregnancies are terminated by therapeutic abortion in this age group. It's still, teenage pregnancy is still one of the highest rates in industrialized nations. The younger the teen when she first gets pregnant, the more likely she is to have another pregnancy in her teenage years. Just over 1/3 of adolescents who have had an abortion or a recent birth become pregnant again within 2 years. Among American adolescents, there is a great peer pressure to become sexually active during these teenage years. Early adolescence is considered 14 years of age and younger. These teens perceive their locus of control as external. That means that their destinies are controlled by others, such as their parents and school authorities. They may fear rejection by family members and peers due to pregnancy. Normally, they'll come into a healthcare provider with a parent or a grandparent. They look to their parents to help them make decisions and for approval of a decision. And in this age group, pregnancy is probably not the result of an intimate relationship at this point. So abuse definitely needs to be assessed. This group of adolescents may be self-conscious and have low self-esteem. They're likely to increase with physiologic changes of pregnancy. They may become more self-conscious with more low self-esteem. The first thing that we need to do with these early teenagers is develop a type of rapport with them, a trusting relationship. That's very important to secure communication during this pregnancy. So a non-judgmental approach is important. Developing their trusting relationship is imperative. We need to focus on their needs and their concerns, and we also include the parents in their care. We also need to discuss options with both the pregnant teenager and the parents, such as abortion, carrying the pregnancy, and adoption. Implications, nursing implications, we need to provide realistic, concrete discussions regarding these options. We need to respect their modesty demands during a physical exam, such as keeping them covered everywhere that we can, except for the area we're assessing. Speaking and communicating with teenagers using simple and concrete terms. And you also want to tell them what you're doing, give them information and a heads up before each step of the physical exam. So you never want to touch a teenager or a woman, for that fact, without telling them what you're fixing to do. Middle adolescent is age 15 to 17 years. This is a challenging time for the teenager. This is time that you see them using, maybe experimenting with drugs and alcohol and sex. They, again, will fear rejection by their peers and parents when becoming pregnant. Not sure who they could confide in. And at this stage, the partner may be used as a confidant if the relationship is ongoing and a caring relationship. Economic dependence or financial dependence is still usually on parents. Factors that determine whether they'll carry the pregnancy or decide on other options include their plans for education, their lack of or presence of support by their parents. And at this stage, their value system may start differing from their parents. Nursing care for middle adolescents, again, non-judgmental approach. We want to be reassuring regarding confidentiality. You have to be aware as a professional of state laws and the potential for consent that may need to be signed for these teenage adolescents. Late adolescence is 18 to 19 years. These women will come in more at ease with their individuality and their decision-making ability. The ability to understand concepts and accept the consequences of their behavior is more prominent in this age. Most likely, they're going to confirm the pregnancy on their own at an earlier date before they present to the healthcare system. And you'll see an increased acceptance and awareness of the consequences in this age group. Poverty is a major risk factor for adolescent pregnancy. Adolescents who do not have access to middle-class opportunities tend to maintain their pregnancies because they see the pregnancy as their only option for an adult status. Intelligence and academic ability are positively associated with delayed sexual activity and greater use of contraception and lower rates of pregnancy. The higher a woman's educational level, the more likely she is to delay marriage and childbirth. Developmentally, adolescents, especially younger ones, are not yet able to foresee the consequences of their actions. As a result, they may have a sense of invulnerability. Texting is a form of flirting and social behavior that's become commonplace among teenagers. Sexting is associated with increased likelihood of being sexually active and of engaging in risky sexual behavior, such as using drugs and alcohol before sex and having unprotected sex. Also, multiple partners. Pregnancy desire tends to be higher among teens who have greater perceived stress in their lives Evidence suggests that teens who have a history of sexual abuse, physical abuse, or neglect are more likely to give birth as a teenager than those who have not been maltreated. In the very young adolescent, incest or sexual abuse should be suspected as a possible cause of pregnancy, and also acquaintance rape. Unplanned pregnancy for an adolescent can result in a lot of adverse outcomes for both mom and baby. Risks are even higher among vulnerable populations. Adolescents older than 15 years who receive early, thorough prenatal care are at no greater risk during pregnancy than the women older than age 20. But begin prenatal care later in pregnancy. Teenagers ages 15 to 19 have a high incidence of sexually transmitted infections, herpes virus, syphilis, and gonorrhea, and the incidence of chlamydial infection is higher. It greatly increases the risk to the fetus. Preeclampsia is the most prevalent medical complication of pregnant adolescents. The major psychological risk to the pregnant adolescent is the interruption of her developmental task. Adding the task of pregnancy to her own developmental task creates a huge amount of psychological work, the completion of which will affect the adolescent and her newborn's futures. Fewer than 2% of teenagers who give birth before age 18 obtain a college degree by the age of 30. Many teenage moms drop out of school entirely during their pregnancy. Approximately half of the fathers of babies born to adolescent mothers are not teenagers, but they're 20 years of age or older. Teens in poor, recently immigrated populations are especially likely to have older partners. Adolescent males tend to become sexually active at an earlier age than females, and they have more sexual partners in their teenage years. Adolescent fathers face many of the same psychologic and sociologic risks as the adolescent mother. In general, adolescent males tend to view an unintended pregnancy as negative because of the impact on their aspirations, their life goals, and their current freedoms. Fathers are included on birth certificates far more frequently today than in the past. Suspect any of the first three causes. Further investigation into the situation is important for the well-being of the pregnant adolescents, and referral to other resources should be made as appropriate. So with rape and exploitive sexual activities, incest, those all definitely need further investigation. Reactions from family and support groups. If they are a fostering, educational, and career goal family, they may present with shock, anger, shame, and sorrow. If the families are more socially acceptable, you may see them react with supportive, involved. They may have friends who are teen parents, and the father of the baby, adult status, and may have a sense of pride. Remember that this may be the first time that the adolescent has ever provided a health history. So in establishing a nursing plan of care and assessment, we may have to be very patient and include others with information as needed. Assessment of history of the family and personal physical health, developmental level, and impact of pregnancy on this developmental level is important to assess at this age. Emotional and financial support, family and social support network, and father's degree of involvement. This is all added to the regular assessment we do with any pregnant woman. Nursing diagnoses that are common is imbalanced nutrition less than body requirements because of poor eating habits, and risk for situational low self-esteem related to an anticipated pregnancy, especially in this age group, is appropriate. Other nursing diagnosis that is applicable to any pregnant woman in general also apply to the pregnant adolescent. Prenatal interventions include nutrition assessment counseling, assessing for high-risk conditions, testing for STIs and educating on prevention, education about substance use, promoting family adaptation, and facilitating prenatal education. So we need to encourage them in childbirth classes, especially if there are childbirth classes available for adolescents or teenagers only. Labor interventions include sustained presence. Someone needs to be with them at all times. The adolescent usually prefers their mother as a support person. They need to be educated about the choices they can make and the consequences with the choices. Also, we need to help the support people understand this information as well and their role beside the mom. Postpartum interventions that are important is contraceptive education, community resources that helps them with this, and other information, community resources on parenting. Be sure to involve the father in this information. If pregnancy occurs early, thorough prenatal care is the strongest and most critical determinant for reducing risk for the adolescent mother and her newborn. Community-based agencies can help adolescents access resources in the healthcare system, as well as social services and other support services like food banks and the Special Supplemental Nutrition Program for Women, Infant, and Children, or WIC. Contributing factors for women who are pregnant at age 35 or over. 14.9% of all births occurred in women age 35 or older. Single women or couples who delay childbearing until they are older tend to be well educated and financially secure. Risk for the women over 35. In the US and Canada, the risk of death has declined dramatically during the last 30 years for women of these ages. Risk include that they may have chronic medical conditions already, like high blood pressure, hypertension, or diabetes. They do have a higher risk for miscarriage and stillbirth, preterm birth, low birth weight babies, prenatal morbidity and mortality, and infants with Down syndrome. So these women need lots of support because they know that they face higher risk in these areas. Assessment and nursing diagnosis appropriate for these women include decisional conflict related to unexpected pregnancy, and also anxiety related to uncertainty about fetal well-being. Planning and implementation, we need to respect and support the decisions that they choose to make. We need to discuss risk with the women, identifying concerns, especially regarding their age, and promote strengths. We want to treat their pregnancy as normal unless they do have special healthcare risk, and encourage childbirth education again for these older parents as well. These women face the possibility of bearing an unhealthy child or a child with a genetic disorder. So the first few months are very difficult, especially when they're waiting to have tests done to see if they have a positive baby for a genetic disorder. Amniocentesis screens for Down syndrome can be done after 14 weeks, and they have to wait another 2 weeks for results. So this is very difficult. More than 1 million women of childbearing age report that they have a chronic physical disability that causes them to need assistance with activities of daily living. Physical disabilities may include mobility difficulties that involve upper and lower extremities, such as arthritis, and maybe vision and hearing problems, disorders of multiple sclerosis or cerebral palsy. They may have heart conditions or lung problems. So special consideration needs to be used with these women who have a disability. We need to consider pressure ulcers for women with mobility disorders. This is added to normal pregnancy issues. Preterm labor is a risk factor. So women with intellectual disability need information, usually can be given to them quickly, it's easily accessible, and is easily readable or understandable for them. Communication aids are also helpful, such as videos, in helping them receive information. A family-centered approach in providing high-quality, individualized experience that builds on the strength of each woman rather than their limitations is important.